then start presenting your lecture. Thank you, ma'am.
Thank you. Thank you for the kind introduction, Dr. Kiran. Am I audible?
Yes, you are audible, madam.
Okay. Good evening, everybody. At the outset, I would like to convey my thanks to the VAA Alumni Academic Forum for giving me this opportunity to speak on the basics of pain management. Pain is an ubiquitous symptom of disease as well as dying, and it is as old as human mankind. The WHO has said that pain is the fifth vital sign after TPR and blood pressure assessment. So the identification, assessment, and management of pain is one of the quality indicator of the healthcare system. The IASP, that is the International Association of Study for Pain, defined pain as an unpleasant sensory, that is corresponding to the somatosensory, peripheral, and central nervous system, and emotional, that is the limbic system. So it defined it as an unpleasant sensory and emotional experience associated with actual, that is obvious, or potential tissue damage. Potential tissue damage as in uncontrolled diabetes causing diabetic neuropathy, or trigeminal neuralgia secondary to the effect of the pulsation of an aberrant loop of the cerebellar artery on the root entry zone of the trigeminal nerve. The IASP in 2020 added certain notes to this definition, which centers the person's lived experience of pain. It says that pain is always a personal experience, which is influenced by biological, psychological, and social and spiritual factors. Therefore, pain is multidimensional and multifactorial. So its management also has to be multidisciplinary. If the biological aspect has to be managed by a pain physician or a physician or an orthopod or a physiatrist, the psychological aspect of pain may need the inputs of a psychiatrist or a psychologist. The spiritual aspect of pain may have to be addressed by a spiritual healer or a chaplain, or as may the need be. The notes also said that pain and nociception are different phenomena, and that pain cannot be inferred solely from the activity in the sensory neurons, and that an individual with pain learns the concept of pain through his or her life experiences. It also said that a person's report of pain should be respected because pain is always what a patient says and how much it is. Although pain serves as an adaptive role, it may have adverse impact on the quality of life of the sufferer. It also concluded by saying that verbal description is but one of the several behaviors to express pain, and that inability to communicate does not rule out that the patient is having pain. As far as the causes for pain is concerned, cancer is the most common cause for pain, with 2/3 of advanced cancer experiencing pain. Non-cancerous causes also cause pain, basically because of the pathologies like degeneration, trauma, vascular, inflammatory, or infectious insults. And various systems may be involved, most importantly, the musculoskeletal nervous system. Pain also happens at end of life or the dying phase. Now, end of life is a phase of life or end of life, which has got complex transitions and is characterized by a huge burden of symptoms, pain being the most common of it all. Also, existential distresses like death anxiety, so on and so forth. So here also, pain is multidimensional, and therefore its management should be multidisciplinary. So in nutshell, even if pain cannot be prevented, relief is imperative. Now, a pain physician or a pain physician to be should be aware of certain cohorts who are at the risk of under recognition and under treatment of pain. So what are these cohorts? Most common of them are the pediatric age group. The misconception that they are most of the times attention seeking, or that their nervous system is not well developed, or the fact that the attending physician is not well versed using the pediatric dosage, or the fear of addiction or making the patient tolerant to the opioid analgesics may all contribute to under treatment of pain in pediatric age group. Likewise, the older people may have the misconception that they have to be stoic about pain, or that they may get addicted to the opioids. So moving on to the pre-verbal or the non-verbal, they may manifest pain as aggressive behavior or combativeness for the very reason that they are unable to communicate pain. The cognitively impaired may present pain as agitation or delirium. Then there are few who deny pain for whatever reasons best known to them. Language at times cause difficulty in pain assessment and its management. Cultural considerations like having to be stoic, gender biases like the fairer sex has got a very low threshold to pain, or the association of pain to be a consequence of karma or the past deeds. These are all some of the cultural considerations that can pose risk to actual optimum treatment of pain. Then the addicts. This cohort may actually be having severe pain because of various reasons, but the label may preclude the physician from treating pain adequately. So the effect of unresolved pain is varied. It may cause even depression. It may increase physiological stress and anxiety that may present as palpitations or dyspnea. Severe unrelieved pain can limit mobility, which in the long run may cause pneumonia or thromboembolism. At times, chronic pain, which causes the release of various cytokines, can interfere with the immunosurveillance of the patient. Moving on to the barriers to pain relief. So the barriers could be of two types. It could be barrier to the administration of pain relief and barrier to seeking pain relief. Barrier to administration of pain relief can happen because of the physician causes. Like many physicians may have the paternalistic attitude that pain is all that is in patient's head and not actual. Or they may have certain hesitations in using opioids because of its dependence potential, diversion issues, addiction potential, or the fact that tolerance can develop. Or they may not be well versed with the dosage and the formulations, and there is a hesitancy in updating their knowledge. Or they may be unwilling to get into the legal hassles of procuring the license and thereby procuring, storing, and dispensing the opioid analgesics. There are barriers from the healthcare system also, and some of the reasons could be the fact that the healthcare system does not appreciate that pain relief is a patient's right. And many of the pain treatments are not going to give them any reimbursement. So the financial aspect is there. Or they may be unwilling to invest in education endeavors for their manpower. Or they also may be unwilling because of the legal hassles involved in procuring the license storing, dispensing, maintaining the logbooks of opioid use. The barriers can also happen from with respect to seeking the pain relief, and this is with respect to patients who are seeking pain relief. So what are the barriers that they perceive? Many of them may feel that pain means disease progression or recurrence, and they may not want to address it or have it addressed. Some may feel that they are going to appear weak, and that may reduce their chances of getting treated. They may not want to distract their provider by keeping on whining about their pain. Some may feel they will appear drug seeking if they express their pain pattern. And many patients believe that everything will be done by their physician, which is far from what happens. Because as I told in the first slide, pain is always what the patient says and how much it is. So one of the most important strategies to overcome the barriers, either at the physician level or at the healthcare system level or at the patient level, is persuasive education. So in this advocacy for giving freedom to the patients from pain, it is not only the doctors, but also the nurses who have an ethical responsibility to relieve pain and suffering. So what are the clinical practice guidelines for quality management of pain? They are involving multidisciplinary care, to have regular and ongoing assessment of pain. The pain relief that the physician gives to the patient and family should be acceptable to them. The response has to be documented. The barriers have to be identified and addressed. Cultural considerations should be kept in mind. The family or the caregiver have to be educated. The suffering that is associated with pain has to be addressed. The goals of pain assessment are twofold. One is to determine the pain diagnosis, and the second is to assess the response to the pain interventions. As far as the pain diagnosis is concerned, an effort should be put to understand the etiology of pain and to understand whether the origin of pain is nociceptive or neuropathic. What do you mean by nociceptive pain? So you have the nociceptors, which are high threshold sensory neurons, widely distributed in the body, the skin, the skeletal system, the muscles, the viscera. So these neurons have got the capacity to transduce. Transduction means the ability to convert one form of stimuli into another form. Like the environment can give us three types of stimuli: the chemical, the mechanical, or the thermal. But the nervous system is not compatible with this form of stimuli. So the nociceptors have got the function of being able to transduce these environmental stimuli into electrical stimuli, which our nervous system understands. So the nociceptors not only transduces the stimuli, but it also encodes these noxious stimuli. So the word descriptors used for the nociceptive pain is commonly the localized sharp pain, the cramping pain, the squeezing pain, or a dull aching pain, so on and so forth. Coming to the neuropathic pain originates because of disease of the somatosensory nervous system. And the common word descriptors used here are shock-like sensations, burning, tingling, essentially the paresthesiae, dysesthesiae, etc. So the pain can also be diagnosed from the chronological point of view, as in to understand if it is acute, that is, whether it has stayed for less than 12 weeks, or chronic, whether it has exceeded 3 to 6 months. And the second goal, as I told you, is to assess the response to the pain intervention. Now, in the assessment, the pain experience is an important step which guides our management also. So what does the documentation of pain experience involve? One is to understand since when has the pain been? What are the word descriptors of pain that a patient is using to explain his pain to us? What does the pain mean to the patient? How much is it impacting his quality of life? So all these descriptors can be understood or applied by using a mnemonic PQRST plus 2, which encompasses all the pain attributes of a pain experience that a pain physician can keep documented. Here, the P stands for precipitating or aggravating, and palliating or relieving factors. Q stands for the quality of pain. R stands to know whether there is or no radiation. S, the site, and since when. And T stands for the temporal factors. That is, whether the pain pattern is continuous baseline or continuous with intermittent exacerbations or intermittent. And as far as the plus 2 is concerned, it goes on to assess what has the patient tried to relieve his pain and has it worked for him. And the second thing is, how is the pain affecting his quality of life? Does it impact his mood, his sleep, his appetite, his ability to do work, mobility, the activities of daily living, etc.? So one of the important component is assessing pain. And the most common pain scale that is used is the numerical rating scale. This is a simple scale which has numbers from 0 to 10, where you explain to the patient that if he says that the pain is 0, then you understand it as no pain. And if the pain score is between 1 to 3, it will be assessed as mild pain. And if he says 4 to 6, it will be moderate pain, 7 to 9, severe. And if he chooses to say that his pain is 10, then the physician understands it as the worst possible pain that the patient has experienced. In the pediatric age group, it is the Wong-Baker's pain rating scale that is commonly used. So this scale has got a set of 6 smiley faces, which has got various expressions. And each of the face corresponds to some number on the numerical rating scale. For example, the third smiley face, which goes on to say it hurts a little more, corresponds to numerical rating scale of 3, 4. But in India, the rural folk or the illiterate are very comfortable with the rupee scale, where 25 paise corresponds to mild, 50 to moderate, 75 paise to severe, and 1 rupee to be the worst pain. However, the scale is not validated. So the pain experience, as I've told you in the previous slides, should include notes on the cultural considerations of pain, the medication use, the current and the past, psychosocial history, substance abuse, and the goals of care for the patient as well as the provider. Reassessment of pain is very important to understand the changes happening in the pain profile. It also is essential to understand the response to analgesics, whether it is giving relief, if so, how much, how long, are there any adverse effects? Many a times, patients are motivated to maintain a logbook, especially in chronic pain scenario. So all these documentation makes pain very much visible and heard, both from the perspective of the patient as well as the pain physician. So pharmacological therapy is one of the mainstay therapies for management of pain. So there are 3 groups of pharmacological therapies available to us. One is the non-opioids, like the paracetamol and the NSAIDs. Then you have got the opioids, which include drugs like codeine, tramadol, tapentadol, buprenorphine, methadone, morphine, fentanyl. And then you have adjuvants. Adjuvants are a class of drug which has primarily a different action, but ancillarily, subsidiarily, they have got analgesic action also. And the use of these drugs sometimes can be opioid sparing. So the drugs that belong to the adjuvant groups are the tricyclic antidepressants like amitriptyline, nortriptyline, the alpha-2 delta calcium channel blockers like gabapentin, pregabalin, the serotonin noradrenaline reuptake inhibitors like duloxetine, venlafaxine, selective serotonin reuptake inhibitors like escitalopram, fluoxetine, the local anesthetics like xylocaine, NMDA antagonists like ketamine, bisphosphonates like zolandonic acid, muscle relaxants, steroids. So there are plenty of them, adjuvants, which have got subsidiary analgesic action. So I'm not going to go into the depth of these for the need of time, but I'm sure you are all familiar with these classes of drugs, and it's important that one knows when to use them and how to use them. While using opioids, it would do good to a pain physician to be familiar with certain definitions, because even today I see that opioids are used rather unimpressively. Fentanyl patches are used for managing acute postoperative pain. So I thought I'll put this slide just so that we can be familiar while we are labeling patients, and as well as understanding what we are doing with the use of opioids over a period of time. Substance use disorder is the recurrent use of alcohol and other drugs that causes problems for health and in various responsibilities of life. Physiological dependence is the prolonged use of drug causing specific withdrawal syndrome characterized by various physiological manifestations when there is abrupt cessation, dose reduction, or the administration of an antagonist. You call that a patient is having addiction when there is compulsive craving and use of various illicit drugs despite understanding the harms it causes. Addiction is determined hugely by genetic and psychosocial factors. Then, what's the meaning of tolerance? Tolerance is adaptation to the effects of drugs needing increased dose to get the desired effect, and opioids commonly exhibit this property. So why are we worried about opioid? Well, the US is now facing the opioid abuse epidemic, and it is a huge cause of death there. So the challenge is, how do we reduce the pain but contain the harm caused by the misuse of opioids? And how do we protect access to opioids for those with life-threatening illness? That is, to use it where it is really indicated. The answer lies in having the right knowledge and applying it rationally. As far as the routes of administration is concerned, you know that most of these drugs are available as oral formulation. The transdermal formulations are available for buprenorphine, fentanyl, diclofenac, ketorolac, lignocaine. Buccal preparations are available for the fentanyl drug as fentanyl lollipops. Buprenorphine is also available as sublingual preparation. Tapentadol buprenorphine is available as nasal sprays. Paracetamol diclofenac is available as rectal preparation. Somewhere in the past, even tramadol was available. It's no more available. And as anesthetists, we know that many of these are available for parenteral administration, including the neuraxial administration. Moving on to the principles of pain management. So a pain physician should be familiar with the use of the WHO ladder, should know how to titrate the opioid dose, should have familiarity with the long-acting medications, should know the concept of opioid rotation and doing the rotation based on the principle of equianalgesia, have a knowledge about addiction potential of the various drugs that is being used, know about interventional therapies, as well as non-pharmacological techniques. The WHO gave the WHO ladder, and it maintains that the step ladder approach benefits 80 to 90% of cancer patients from getting relief of their pain. So this is a 4-step model. The step 1 strategizes the administration of non-opioids like paracetamol and NSAID with or without adjuvants for a pain that is mild in intensity, that is NRS 1 to 3. Step 2 gives recommendations for the use of analgesics for moderate pain, that is NRS 4 to 6. And the drugs mentioned are weak opioids like codeine, tramadol, tapentadol, with or without non-opioids, with or without adjuvant. The step 3 is for pain which is severe and NRS 7 to 9. And it recommends the use of strong opioids like methadone, morphine, fentanyl, and buprenorphine. Step 4 is not put here, but it involves interventions for very severe pains. So there are 2 riders that come with this WHO ladder. One is that at every step, the biopsychosocial-spiritual model is maintained or it is addressed. And the second rider is that this 4-step model is a very flexible ladder. Like when a patient comes in severe pain, you can use the recommendations in step 4. And once the pain is under control, you can come down to step 1. Moving on to the principles of opioid dose titration, the physician has to be familiar that there are immediate release formulations, there are sustained release formulations, there are immediate release formulations that is used in a particular fraction to address the breakthrough pain. So what are breakthrough pains? These are basically sudden, severe onset of pain in an otherwise well-controlled pain. And it is secondary to either the end of dose or because of any movement, which is referred to as incident pain. Or at times, there may be no rhyme or reason for its onset. So this breakthrough pain is addressed by using 1/6 the total daily dose of the opioid analgesic that is used for a given patient. So when one opioid is ineffective, or even with inadequate titration, or when there are adverse effects that are manifesting which are unmanageable, a physician can resort to opioid rotation or switch. But while doing this, one has to follow the principles of equianalgesia. So equianalgesia is you first estimate the total daily drug dose, and there are a lot of ready reckoner charts available. It's virtually impossible to remember the conversion charts. So you find out the morphine equivalent of the drug you want to switch over to. And a caveat given is that you reduce the dose of the new opioid by 25% when you are doing the rotation. Cancer, in addition, has got several other modalities of treatment to address pain. Like the pain due to bone mets can be addressed with radiation or hormonal therapy or bisphosphonates or radionuclide therapy. Surgery sometimes can be resorted to relieve the pain of intestinal obstruction. Chemotherapy reduces pain by reducing the tumor burden. And then there are interventional therapies for cancer and chronic pain. neurolytic blocks like celiac plexus, hypogastric blocks, plexus blocks. Then there are neuromodulation procedures like radiofrequency pulsing or radiofrequency ablation, single shot steroid injection, dry needling for the neuromuscular pains, vertebroplasty or kyphoplasty for vertebral fractures due to cancer or osteoporosis. So interventions with medications and procedures impact the pain relief and improve the quality of life of a patient in pain. I've just put a few images. So this lady, she was a 25-year-old lady from Bellary with a 6-year history of lower abdominal pain. And one of the causes that was, one second. She had a past history of tubectomy, and examination revealed that there could be an entrapment of the rectus abdominis cutaneous nerve. So we did a pulse radiofrequency of anterior cutaneous nerve, the ilioinguinal and the iliohypogastric nerve. And it's been 6 months since we have seen her. She is having good pain relief. I'll just start the video. So you can see the RF electrode pulsing for the motor with the motor stimulation. And that's the ultrasound picture where you can see the motor stimulation of the rectus abdominis muscle. Moving on to the next case. We had a 44-year-old man with the history of right-sided cluster headaches, 20 years in duration, the intensity and attacks which had increased in the past 2 years. And at presentation, he was getting an average of 2 attacks per day, with each attack lasting for about 2 hours. And he said the pain was like a stain above the medial end of the right eyebrow. So patients use various pain descriptors for pain. And he also complained of mild headache.
Sir, please go ahead.
Yeah.
Somebody has not muted.
Yeah, it doesn't matter. And the patient also complained of mild heaviness on the right side of the posterior part of the neck. So I administered a supraorbital nerve block that is steroid based. You can see the supraorbital notch and the steroid administration raising a hypoechoic halo around the nerve. And this was supplemented with the supratrochlear nerve block. You can see the needle through which the steroid is being administered. And this site was midway between the supraorbital notch and the root of the nose. And then we also did the suboccipital triangle injection to address the activation of the greater occipital nerve as it emerges from the C2, C3 foramen. And you can see the hypoechoic shadow raised between the planes of the semispinalis capitis muscle and the inferior oblique muscle. And this is the lamina of the C2. Similarly, we had a 13-year-old who had come from Bangladesh in pain crisis while being evaluated for possibly Ewing sarcoma. So on the left side of the screen, you can see that the child is all curled up into a ball because of severe pain. He's unable to assume a supine posture. So there was a change in the pain behavior once the paracetamol, morphine, and dexamethasone was administered parenterally. You can see that he has assumed a far more comfortable posture than he was in the other picture. This boy, 15 years old, from Kolkata, he was a medical aspirant, was suffering from complex regional pain syndrome for 18 months at the time of his presentation to our OPD. We tried to figure out the cause for sensitization of the central nervous system, and only two possibilities we could narrow down. Was it a fall in the gutter on the right shoulder 6 years ago while he was playing with his friends? Or was it a history of childhood meningitis? So finding the etiology of chronic pain can sometimes be like finding a needle, searching a needle in a haystack. Anyway, the image on the left shows how much disability he had in his working hand, that is the right hand. He was unable to make a fist or hold a pen for his educational activities. The image on the right is subsequent to the administration of a stellate ganglion block. You can see that there is ptosis, chemosis of the conjunctiva, and mild tearing also if you really look hard, probably. So this is the ultrasound guided stellate ganglion block that was done. You can see the plane that is separated below the internal jugular vein, the carotid, and above the longus colli muscle. So the steroid was administered, and this is the lamina of the C6 vertebra. It's a long video, so I'll move on to the next. So 2 years post-procedure, he came to our OPD recently. And this is the video showing his right hand. He's able to make a fist, and was able to write also. And his neat preparations are in full flow. This is the testimonial he left us with. So chronic pain results are not easy to come by. Many times they're not completely relieved. So in such scenarios, patient testimonials can be really rewarding. The last image is of a 56-year-old female who presented with severe pain in the left buttock, and her Faber test was positive. She had excellent pain relief post a sacroiliac joint injection. So moving on to non-pharmacologic strategies, which are simple, reproducible, and empowering to patients. There are physical therapies which aim at rehabilitation of the patient, and electrical modalities like TENS, etc. Psychological strategies involve biofeedback, cognitive behavioral therapy, systematic desensitization. Complementary therapies include acupuncture, Reiki, hypnosis, meditation, etc. So in summary, pain relief is contingent on adequate assessment and use of drugs, interventions, and non-drug therapies. Pain is multifactorial, so the management should be holistic and should address the biopsycho, socio, and spiritual angles. Interdisciplinary care for total pain relief is mandatory. So thank you all for patient listening. I think I have exceeded my time by 5 or 10 minutes. My apologies on that.
Thank you, madam. Thank you. That was a seamless, crisp, and comprehensive presentation. So the forum is open for questions and discussion. So, Gurudas sir,
Can stop sharing?
Yes.
If I can stop sharing.
Yes, I've done that.
So excellent lecture, Dr. Renuka. So nothing to say anything about the lecture as such. And especially your own experiences of many of the patients you also shared was really very good. So I didn't know that you have so much of experience in pain management as such. And I also didn't know that you have done your fellowships and all. So really congratulations to you.
Thank you, sir.
We also have the pain unit in our JSS hospital. So we also have the fellowship also. I think for the past 3 years now also we are conducting. I think you may be knowing, and it's a fantastic, the pain medicine unit. As such, anywhere for that matter, the management of chronic pain. Even you were talking about one cluster headache patient. Even I had a cluster headache long back when I was in armed forces. So somehow I suffered for almost 2-3 years. I don't know how it just disappeared like that. So probably if I was having now, I would have come to you only after.
You are lucky, sir. I think it's a worse form of pain.
Yeah, correct. It was like, suddenly in the night I used to get, especially in middle of my sleep, I used to get up, and then it used to be a very short duration. That's why I think it was called as cluster headache. Yeah. It was like I was feeling like banging my head against the wall also. It was so terrible. So
it's cyclic. Yeah. And I think it's because of the hypothalamic circuits getting involved or something like that.
Yeah, but one thing, Geriatric, I just want to ask you, just one block of the supratrochlear and supraorbital nerve can produce so much of relief. It can be long-lasting relief. How is it possible?
So we normally use deposteroids like Kenacort, triamcinolone. So that normally gives relief for 3 months because it's a depot preparation. But we don't ask the patient to stop their baseline medications immediately. So this is just about a month since I gave this patient this block. So we don't know how he pans out. Sometimes it's all about cutting that arc of that
reflex arc that is there.
Cycle. Yeah.
But it's really fantastic. Thank you so much for the nice lecture. Thank you.
Glad you liked it, sir.
Yeah. Ma'am, we have 2 or 3 questions in the chat box. So first 2 questions are by Dr. Pradeep. He asked for role of alpha-2 agonist in chronic pain and where do they stand, and whether do you use oral chloride. You got the question, ma'am?
The alpha-2 agonist that I use is only tizanidine. I don't use clonidine. And I don't use oral clonidine. So anyway, they come as adjuvants. Have you used it, sir?
Pradeep?
If you are on.
No, madam, I have not used it. I have not used it.
Right?
Yeah, I have not used it in chronic pain. I've used it. We have used infusions for intraoperative pain, postoperative pain, yes, as adjuvants, but never for chronic pain.
Even I don't use it. I'm not, except for tizanidine. Tizanidine is a good muscle relaxant action is also there. So, a good add-on.
Nazir can opine.
So this we are using in calf muscle pain actually. Patients coming with a calf pain, night pain, usually we do this trial of clonidine. Are you audible?
A little bit louder.
Also audible. No, this clonidine is used in the patients with having a complaints of calf muscle pain, especially night pain, and they're not responding to the other medication. We try this, usually they respond, the mechanism is not explained. But this clonidine drug is very useful in the calf muscle pain. It's very common complaint in the pain clinic. But still the clear cut, this one is not there, how it works. But this is one of the mode we are using to treat.
So we have one more question from Dr. Vivek Patnam Dinakar. He asks how to enforce anesthesiologist-driven pain protocol for post-op pain management.
How to enforce this?
Enforce anesthesiologist-driven pain protocol for post-op pain management.
Vivek, you are there.
I would appreciate the protocol given by the anesthesiologist for post-op pain management. It's okay. Whatever.
And he is asking how to enforce it.
How to enforce it? Okay.
Yeah.
Okay. All right.
Dr. Vivek, you are there. No, he can come. He can put on the video and come. That's what I said.
It is.
Sir, am I audible?
Yeah, sir, you are audible.
Enforcing has to be done even by the pain physician.
When the surgeon and the
Sometimes.
anesthesiologist are at disagreement, how do we enforce?
If who and who are at disagreement?
Surgeon and anesthesiologist are not in agreement.
Okay. Yeah. Anyway, that's a common story inside and outside of OT, I guess. Well, sometimes when I go for the second visit and I realize that they have not followed, first thing is, I believe that they've given a reference to a pain physician because they want some extra inputs into the management of pain. Now, despite that, if they choose not to follow it, I write the reason why I have suggested that, and that I will review it on need basis. After all, I mean, you've got to live with your colleagues. So, but at the same time, you should never get a feeling that you have been walked over. So that's the way I would do it. And enforcing, it should never be enforced because there is no longevity to enforcement, I guess.
Yeah. So
it has to be talked. It has to be deliberated.
Yeah, it's an institutional protocol. It must be followed. It must be established after mutual discussion and agreement. So what I would anyway, to Dr. Vivek's opinion, what I would probably, what he probably wants is what could be the type of initiatives from anesthesiologists that could be taken to see that the perioperative pain management gets better in the different institutions. Because enforcing is never the way. We are not going to talk about enforcing. It's not possible. And generally, it's a teamwork, as you said from the beginning. So probably you may just tell your ideas how we can sensitize the surgeons and how to put a system in place.
If I have to give an example, many of the surgeons post-op orders has IV PCT SOS, IV pethidine 25 milligram 4th hourly or 5th hourly. And then the pain is not under control. And the pain is purely surgical site. So here the need of the situation is to probably increase paracetamol as an analgesic and administer an anti-inflammatory if there are no contraindications to it. And pethidine, we know it's a weak opioid, and there is no sustained pain relief with that. Instead, a tramadol or opioid, depending upon the pain intensity, would be a choice. So even today, there was a reference for a patient who was on epidural catheter, which was running fentanyl and bupivacaine, and they said that the patient's pain was not under relief. So we saw the site was quite good. What had happened was the infusion had stopped, and it all wanted that re-administration. So many times it's the camaraderie that you have with your surgical colleagues, and the best way is to make them understand why you are putting the protocol as you are wanting. That's where the power of dialogue is probably.
Anti-inflammatory, which one would you say? There is confusion about diclofenac.
So most of the surgical cases will be NBM. So only diclofenac and ketorolac are the options, or rectal Zonac. It's an acute pain.
Yeah, I understand, but still the protocol is not set in majority of institutions. As you say, they will say SOS updates and some inadequate dose of an opioid alone, and paracetamol, despite the potential as a supplement. Of course, we know it's not too good a drug for perioperative pain. Even that has not been put into a routine use in majority of the cases.
So another problem, Bhaskar, what I have seen is as the majority of the anesthesiologists do not, get involved in the management of postoperative pain.
Yeah.
They most of the things times they just leave it to the surgeons to manage. So
Yeah.
that is the problem in majority of the institutions, and even the postgraduates also, they don't do the follow-up. And what is happening in the for the patient as far as his postoperative pain is concerned, they just don't follow up. And they think that their job is over once the patient is shifted from the OT into the postoperative ward. So that is the majority of the times how the surgeons, they themselves start managing the pain, and usually that many times it may not be a good amount of pain relief. Majority of the times it may be an inadequate pain relief. What I suggest is we should try to get involved with this postoperative pain management as much as possible. Then probably even the surgeons will just leave everything to us only for managing the postoperative pain. So I think that should be the solution.
In fact, our acute pain management has become restricted to intraoperative period.
That is what I was trying to tell.
Probably at least in the postoperative period, we should use our knowledge. That knowledge is not put into use. That's a problem.
Yeah, because we keep talking about multimodal analgesia as a form for management of acute pain in the postoperative period. So we don't get involved, and that's how some paracetamol or some opioid is being given, and the patient will not get much relief. That is always there.
Yes.
It's adequate dose and adequate time of analgesics. I mean, one should not be in a hurry to stop the medications.
Yeah, at least my opinion is non-sedating drugs must be used to the maximum potential. Non-sedating drugs. So if you are talking about opioids, I do understand in some institutions follow-up could be difficult. Whether it is, as you say, pethidine, or if it is a fentanyl infusion or whatever, where we definitely need a better monitoring. But with respect to some fixed timing and duration of administration of, for example, paracetamol and including contramol and diclofenac, at least that much of benefit must be passed on to the patient.
Is Dr. Vivek in institution or is he a freelancer?
No, he is in the army.
Okay.
He was in Bangalore Command Hospital, and now he is in Northeast.
Okay.
He is an online library. Any books you want, he will supply. Vivek, thank you for that service.
Srinivasan sir, you have a question? You can ask directly.
Yeah, how is a geriatric patient different with respect to pain management? So the whole physiology, since it is different, the dictum is start low and start slow, sir. And I would focus on the comorbidities that a patient has also. So keeping in mind the side effect potential and its clearance. So the creatinine clearance is of utmost importance. Long-standing uncontrolled diabetes, I would be a little careful with NSAIDs. In a patient with history of epilepsy or something, then certain drugs like tramadol would be contraindicated. But the dictum in general is start low and slow. Otherwise, there is no drug that is contraindicated in specific for the geriatric age group.
Most of the times, especially our surgical colleagues, I think they are afraid of post-operative problems like respiratory depression and all. So they will avoid even tramadol also.
That's why, so starting low and slow would be way out. And another thing is to be really safe, then the lean body weight, we have to calculate the dosage according to that. But then it is all going to be a stretched affair. That's where the knowledge of comorbidities will come to help. You know where to go really slow.
Okay, Dr. Anand Bangera has got a question here. Welcome, Bangera. Please highlight about the management of ischemic pains like the TAO, where surgical management fails. uh,
So the option is sympathetic blocks. So if it's upper limb, the stellate ganglion, and if it's the lower limb, the lumbar sympathetic blocks. Again, these are all tough pains actually. And most of the times it ends in amputation also. Acute management we do with opioid analgesics, continuous infusions.
I don't know, Sir Gudas sir, and I mean, such cases have come down. We remember we were part of many surgeries when they were performing lumbar sympathectomy for TO with gangrene and all, and we used to give a trial of at least a block, epidural block and all, and try to see whether there was improvement in pain and all. I mean, reduction in the pain. And now such cases also have come down. Basically, I don't know why.
Maybe reduced tobacco.
Smoking.
Smoking.
Yeah, smoking. Yeah, that has come
It has
down.
come down.
I think.
Nazir, you get any patients of PAO pain in your clinic? You are muted, please. Unmute yours.
So I do cases regularly. Sympathetic block with the phenol, sometimes followed by the radio frequency of that. We get cases. We use it for BAO and this diabetic foot also for facilitating the healing. We get cases regularly in our hospital.
Okay.
Still there, but again, the duration of action is 3 to 4 months or 6 months. We have to repeat again. Again, it helps in the demarcation of the gangrene, all those things. That helps the surgeon in identifying the whether to keep or remove the part. That will help and relieve the pain also. That is the two indications actually.
Yeah. The demarcation aspect is one important thing, basically. And of course, Pradeep has talked about acute pain services, pain rounds to be taken by anesthesiologists themselves. That's a good thing. In the immediate post-op period, we can have develop this habit in the institutions, at least because we have got more number of PGs everywhere. And again, Dr. Vivek has asked what ISM measures to include pain medicine in PG syllabi. Anyway, I will answer the question. There is no, I mean, already all the universities are, which are part of NMC, there is a syllabus which is already there, so curriculum where pain is also given importance. And the only thing is it is left to the individual institutions to implement them. So pain clinic and what should be learned in the first year, second year, third year, all have been clearly explained, especially with respect to the CBM, competency-based medical education related to MD anesthesiology also. I think it's left to us as the practitioners or part of the hospital to implement these recommendations so that the PGs also get benefited. Anything else with regard to this question, Renuka? He was asking about the pain being part of the syllabus.
Yeah, actually the CBME curriculum has introduced pain and palliative right from first year, sir.
First year.
Yes. And even in our institution, the interns orientation, interns exit, they have a station for pain and palliative. And the interns are being rotated in our department for 2 days now. So there is some movement in highlighting the importance of having a department and the field.
One small request is, from our exam going postgraduates, they were asking what are the recent advances which could be part of their final question paper. If you can just brief them, just mentioning that topics 1, 2, 3, 4 in a sequence for them to read, because you are more updated with the recent pain management aspects.
I don't know what their syllabus is covering now.
The fourth paper, they will get a question in the fourth paper of recent advances. So they would also want to know recent advances in pain medicine.
I think spinal cord stimulation, intrathecal drug delivery systems.
Okay.
Dr. Nazir, anything else you want to
No, they should know the basic, how to evaluate the patient. That is a assessment of that what you covered in your topic.
Yeah.
Most of the things will cover in the pain. That is first aspect is identify the cause, history taking, that is covered. Then management, medical management is more important. Then comes intervention, you are covered. But as you said, now neuromodulation is now latest, like spinal cord stimulation and intrathecal delivery systems and radio frequency modes. But they are all advanced actually, and you have got discectomies and other things. But as a postgraduate, they should know the basics because that is covered in the NMC. NMC has already mentioned what is the syllabus to be covered.
Yeah.
So if they go through that, I think they will get. But that is sufficient for them. Recent advances is basically it is very advanced for the person who is already practicing pain. For postgraduate, if they know this one, they will be able to answer. And even condition like CRPS, post-traumatic CRPS or post-surgical CRPS, and post-surgical pain, central pain syndromes, then there is neuromodulation techniques. So it's a vast subject, but this will cover most of their questions.
Simpler questions could be transdermal drug delivery system, patient control analgesia, adjuvants as such. Not recent advances, but then it could come as an offshoot of
a stock question, basic questions.
A stock question. And how does central sensitization happen? I think that's covered in the anatomy of the pain, no, sir? Pain is a chapter, isn't it?
So basically syndrome, pain syndrome, you can say.
Still, we get gate control theory of pain as chapters.
Yeah. The pain matrix.
And they don't know physiology, anatomy of the pain, physiology, and different
routinely asked questions.
Right.
So, any more questions?
Any nice to have you in the group today.
Thank you, sir. It was a pleasure seeing you all.
Dr. Govindrao.
Thank you, madam.
Thank you.
Is online?
There has been a good participation today from other states also. I can recognize the presence of many of our colleagues here.
Actually, I had a surprise in the morning. Dr. Lakshmiva's pain clinic has got a WhatsApp group.
Okay.
And one of the fellows who is in Pune now, she saw the this thing in the Facebook group.
Okay.
And she circulated it in the group. So that's when I realized that it is pan-India. Whatever.
That's in India.
It's there in the YouTube also, basically. Available long time. Nice. Thank you, Renuka.
Thank you.
We will have further presentations from you in future.
Sir, I think we need to have a pain workshop in Bellary, sir. Both Najir sir and Renuka madam should come